Good evening, friends, and a warm welcome to this episode of 4D. This is season 3.0 going on, and 4D stands for Detailed Discussion and Dialogue in Indian Diabetes. And it's important that we continue this dialogue, this duologue, this discussion, because there is always so much more to learn, so much more to gain. And when we have experts, dynamic experts, and the fifth D is D for dynamic. So when we have these dynamic experts, then we gain a lot of insight. It's not just information that we get from 4D, it's insight, it's ideas. And these are very intense, very attractive ideas that we can actually use in our OPD. So let's welcome our guest for today. A warm welcome to Dr. Radha Priya. Madam is a cardiologist at Apollo Main Hospital in Chennai. Warm welcome, madam.
Good evening. Good evening, sir.
And it's great to have you with us. We also have with us Dr. N.K. Narayanan, who is a very well-known endocrinologist working again at Apollo Hospital in Chennai. Warm welcome, Dr. Narayanan.
Thank you, sir. Good evening, delegates.
And I'm personally aware that when in Tamil Nadu or in national endocrinology, when we have to find a speaker for a difficult topic, then Dr. Narayanan is the volunteer. I mean, he's involuntarily made to volunteer for all the difficult topics in our conferences. So it's good to have you with us.
Thank you, sir.
And we also have Dr. Ajay Rathoon. Dr. Ajay is a nephrologist working at Chennai Urology and Robotic Institute in Chennai. Warm welcome, Ajay.
Thank you, sir.
So, Dr. Ajay, in your institute, like you're a nephrologist, and this is the field of, this is the era of specialization, super duper specialization. We have physicians from all across the country. So there is this tongue-in-cheek question for you. This comes from an endocrinologist in Coimbatore, Dr. Prem, and in Salem, Dr. Prem. And he says, Dr. Ajay, do you look after both the left kidney and right kidney, or do you specialize only in one?
We always do the same thing, sir. Both are same for us. Just like
looking after both.
Yeah, both.
And Dr. Narayanan, this question for you. So it seems the standards of anatomy education are, they are breaking each and every record across the world in our new medical colleges. So a question coming for you is, how about you? Dr. Ajay looks after both kidneys. So do you look after both thyroids as well? Or is there a goopy in this question?
Well, as you rightly said, sir, the super specialization is gone to the left. I'm the right heart specialist, as Dr. Radha Priya might now tell. But in endocrine, so far, we are looking after all the body organs, although there are people who are have got a special interest in particular areas like pituitary or particularly in adrenal. Maybe the research work is more in that area. I mean, even for me, my research work was more in adrenal and pituitary. So obviously, I got traction towards that area. But the core endocrinology or the bread and butter of endocrinology is the thyroid and diabetes.
Yeah.
So we look after all.
So just to remind all of ourselves that there is just one thyroid gland and we all look after both the left and right lobes. But Dr. Radha, is that true for cardiology as well? So when I was a student, which was very long ago, 3 decades ago, that time the treatment for heart failure, if at all we would diagnose, would be injection furosemide. And then the story stops there. Now it seems there is specialization in heart failure as well. So is there actually a specialization in left heart failure and right heart failure separately?
Yeah, there's no separate specialization for left heart failure and right heart failure because we treat both of them pretty much the same way. Though fewer drugs are not much for isolated right heart failure. But of late during these years, we do see specialized, just right heart conferences coming up with evolving treatments for pulmonary hypertension, pulmonary embolism, advanced intervention therapies and all. Even with, replacing right side valve stuff, just by intervention. So we have more concentration per se towards the right heart also, in the last 4 to 5 years. So there's like a more concentration and separate specialty development just concentrating on right heart.
These are actually very welcome trends because all those things were there earlier also. We just never thought of them. We never realized them. And now improvements in our understanding, improvement in diagnostics, all these are helping us diagnose diseases which were there earlier, but maybe we were not able to pick them up. And that's why our mortality rates are going down actually. The entire community complains that morbidity is going up, but that is going up because we are able to prevent mortality. And our colleagues in cardiology, nephrology especially, are doing a great job by taking care of our patients. Dr. Narayanan, this is the era and this is the fashionable statement, chronic cardio, kidney, metabolic syndrome. So everybody talks about the heart and the kidney, And then when they talk about metabolism, usually they limit themselves to diabetes and obesity. So would you like to tell us what is the thyroid gland? And does the thyroid have any link with metabolism in general? What does the thyroid gland do for us?
So very interesting. As I always tell in endocrinology, any hormone which is a subtle chemical which we can't even see controls right from top to foot, right from the birth to the death. So right, the physical growth, the mental growth. So to start with the fetal effects, the mother's thyroid gland up until the 18th week of pregnancy, the maternal thyroid hormone gets transferred across the placenta, and this thyroid hormone is the one which stimulates the fetal brain development. It stimulates the physical development for the fetus. Beyond 18th and 20th week of the gestation, the fetal thyroid gland starts working, but still it will not be able to take care of the entire requirement. Therefore, still it's a shared care development between the fetus and the mother. So right from a human being gets into the gestational period as a fetus, and post delivery, when the baby is born, up until third year at least, when the brain development is at its peak, during this time period also, the thyroid has got a very, very important role. And that's why we are always worried about congenital hypothyroidism, which needs to be picked up as early as possible, should not be missed at all. Unlike in adulthood, where if you miss a hypothyroidism, let it say went on for 6 months time duration, it will not have a major impact like in the children or in the neonatal time period. So the brain development in the initial first 3 years of time period for the thyroid hormone is entirely dependent on the thyroid hormone. Post that, the physical development also. I mean, just very coincidentally, just today I saw a 26-year-old male IT professional, unmarried, clinically grossly hypothyroid, was referred for obesity, and the TSH level was 952. He was referred only because he had some hip pain, and the MRI which was done for the hip pain at the age of 26 showed that the epiphyses were completely unfused, which is very unusual for a 26-year-old person to have an unfused epiphysis at this age. This is what triggered the referral, and TSH was 952. We started thyroid hormone replacement, and then he's now slowly improving. So it affects various facets of our life: physiology, the physical development, mental development, reproductive development. For that matter, somebody who's grossly hypothyroid like this, the gonadal axis will be suppressed. So a multitude of effects also are seen when the thyroid hormone is either deficient or when it is in excess.
So multiple effects. This tiny gland, a butterfly-shaped gland, just 25 grams heavy or maybe 25 grams light, and you are saying it affects growth, it affects reproduction, sexuality. It also affects our not only neural and cognitive growth, but also physical growth. And this is actually the paradox of India. On one hand, we should say, yes, it's nice that we are able to send our patients for MRI when they have a pain in the hip. But then the MRI was done before a simple TSH was done. And until 26, nobody ever realized, neither his family, nor he himself, nor the employers, even they didn't realize.
Well, he said, I'm not even aware, I was not ever been told. I thought this is the normal. Even that I was surprised, a 26-year-old male.
This is actually very sad, And let's take Dr. Radha into the picture and Dr. Ajay as well. On one hand, the entire community keeps on criticizing us. The community means India at large. They keep on criticizing us that we are medicalizing normal things. So we are medicalizing menopause. We are medicalizing an EGFR of 59.9. We are medicalizing an anti-pro-BNP more than 125. So while actually the opposite is the truth. Our society has become so used to ill health, to poor quality of life. Somebody with a hemoglobin of 7, she will happily live life saying that, everybody else is sick, everybody else is breathless, so I am also sick and breathless, I am normal. And we are trying to help them, improve their productivity, yet we get bashed up for that. So have you ever faced this in your OPD, Dr. Ajay, Dr. Radha, where we are trying to help someone do better and they get angry at us instead?
So I am from nephrology, so from our department point of view, the symptomatology is very vague, and most of our patient doesn't have any symptoms. So telling the patient you have some disease, it still makes them look at me like a villain. So basically, even if their creatinine is 3 or 4, they don't have any symptoms, 0 symptoms. Most of the time, they present to us with some uremic symptoms when they are GFR less than 15. telling them you have some renal failure itself make them look like I'm a villain. So the symptomatology, there's always in nephrology, there's always a big gap between the symptoms and patient presentation. And just as you said, sir, and when we talk about GFR, before GFR, the protein leak is there. Even with normal creatinine, there is going to be protein leak. The urine ACR is high. When I ask the patient, like the protein leak is there, so there's always when we the microproteinuria, the urine ACR is slightly less than 30, or it is more than 300. So even with normal creatinine, with the hot scale, GFR is 60, which is G2, and with the A3 or with the ACR is around 300 or 400, which puts in the almost like orange or red in the mark. So which means within 3 years or 4 years, he'll be into stage 3 or 4 of CKD. So convincing the patient or telling the patient this is the risk you have is big challenge for us. And as you said, sir, this is a big allegation which we have, and that's big basically because there's a big gap between the symptoms and the disease
numbers.
And in nephrology, usually the patient presents to us late because the symptoms are always late. The hypertension doesn't have any symptoms. As you know, diabetes doesn't have any symptoms. Whatever is written in our test books, it's very rare. Whenever we say like you are diabetic, you are hypertensive, I don't have giddiness. I don't have this symptom. I don't have headache. That is the first thing they say. So your BP is 190, sir. No, I don't have any symptoms. I don't have giddiness. That is what they say. When we say you have diabetes, your HbA1c is 10, and you have protein leak. I don't have any symptoms, sir. I'm totally normal. I'm working very well. I have no symptoms. I don't urinate in the night. I don't have any symptoms like tiredness. What you're saying, your HbA1c is 10 means you're just some bogus you're telling. But all of a sudden they have all symptoms. So
and I really empathize, and I'm sure each and everyone who is listening to you, physicians from across the country, they would have empathized and compathized with Dr. Ajay when he said we are treated like the villain. So first of all, we diagnosed, we are trying to help you out with an A1C 10 or a creatinine of 3.3. We are trying to help you at least get some kind of attention now, and still we are being treated as the villain. And actually the person who diagnoses first, he or she is treated as the worst villain. By the second, third time, then they are okay. Then
the one who breaks the ice, one who tells the right thing is always treated as a villain. And that's the only another person who's nothing is going to be wrong when you take this medicine to be all right. There are a few people who tell that, probably in alternate medicine also. Probably they'll be treated much more as a hero. Then when we tell the bitter truth, we always treat it as a villain.
Yeah, I understand. And now going back in my career, when I look back, actually practice was much easier 20, 25, 30 years ago. We had less tests, we had less therapeutics, but it was not so much of an issue convincing the patient. If the patient comes to you, you assume that the patient has come in a way that they will listen to you, and whatever is possible, they will take it. They would be upset with insulin. Of course, if you tell someone to go on dialysis, they would get upset, but there would never be any argument, there would never be any fight, and no one would ever accuse you of doing wrong. But now people come with a mentality that the doctor is doing wrong, a physician or a specialist, and until you prove otherwise, you are wrong. That kind of a challenge I am facing more and more frequently now in practice. Dr. Radha, is it like that in cardiology, that instead of trying to fight the disease, they end up shooting the messenger? You are a messenger of good health. If you want to achieve good health, you have to tell them current health, but they end up shooting the messenger only. Does it happen in cardio?
I think it happens very frequently, that especially I think compared to the Western population in India. We all know that the cardiac symptoms are also very much subjective. So I would say out of 10 patients, not even 2 patients would actually complain of chest pain. Even though, unless they come with a, MI or a ACS presentation, most of the chronic stable angina patients or whom we see LV dysfunction is there and we do angios, we see such critical diseases, but when we actually talk to them, they say, no, we have been fine, doctor, we don't have any symptoms, absolutely no chest pain. Sometimes when we see left main disease and all, it's quite surprising that how they have been actually doing regular activities also with so much ongoing skill. And putting boundaries apart, even once they start to feel, when patients have LV dysfunction, even the leg feeling, some sort of breathlessness, and when they feel uneasiness in the night, orthopnea and stuff, we see a lot of people coming very late, 2 months of symptoms, Only when we retrospectively start asking them questions, then they were like, okay, this was there for the past 2 weeks, 3 weeks. So I think there's a lot of reluctance in actually seeing a doctor. Let it be, a nephrology or cardiology, irrespective of them having all these symptoms. They're just so reluctant, maybe because like you said, previous days probably they would trust the doctor, go and see and feel they find a solution. But now they probably feel that they're just going to make us spend money doing a lot of investigations, or I think they just want solution than knowing what the problem is. I still feel that is the current scenario we still living in actually. They just want answers or treatment more than trying to tell them, let's see what the ongoing problem is. And I think also I have come up with a situation. See, you have your, elderly parents who have heart issues or something. So we see the middle-aged, the daughters or the sons who come to us who are actually obese, who have never tested themselves, not in the lipid profile, not a HbA1, TSH, even though, they probably will be touching their 40s or 45. They just feel they're healthy, they're going to work and coming. They know they have family history of heart disease, but never managed to test themselves even once. So I think there's so much reluctance even in the younger generation, in fact.
All these things are very important, and of course, if we all begin doing our best, we are already doing our best, but maybe we can do better in terms of communication. We communicate with the patient, with the caregivers, even though we are irritated, frustrated, tired, and we communicate with the community at large. Gradually, this message of good health and proactive healthcare will spread. But let's come back to that thyroid gland. Dr. Narayanan, now some things are easy to diagnose, isn't it? And others are very difficult to diagnose. Let's take diabetes or chronic kidney disease. It is difficult to diagnose these diseases because the symptoms are very, non-specific. In cardiology, at least, most people will come with chest pain or with discomfort. The anginal equivalents are also well delineated, so you can figure out in the OPD. But these are tough things to do. But there is a difference. When someone goes to Dr. Ajay, Ajay can very confidently say, yes, I have a good quality laboratory. I trust my serum creatinine and EGFR calculation. I trust my albuminuria. Can we trust our TSH? That's the question. So first of all, the symptoms, the signs were non-specific. The TSH, how good is that value? How bad is that value? Any challenges that you faced in practice?
I think as if it is not an accredited laboratory, people it's very uncommon for even physicians to understand how important it is to know which lab the assay is being performed. Things as simple as, for example, glucose. People don't realize that they take a blood sample for glucose, store it, go around for home collection, then the sample reaches the lab, by which time 3 to 4 hours might have lagged, and the glucose value will artificially be low than what actually it is. So the sample handling, understanding, etc. is still lacking in India for various reasons. One interesting thing about the thyroid profile handling or the thyroid sample handling, it's a serum sample, so it doesn't need any special storage, unlike for like glucose or ACTH or other hormones. So the serum is quite stable for analysis of TSH. But when it comes to the lab, there are so many variable methodologies to assess the thyroid function test. For the physicians understanding the thyroid hormone, the TSH, free T4, free T3, all these can be analyzed with various assays. I think endocrinology is one field where we so closely interact with biochemistry because of this reason particularly. There are one-step assays, two-step assays. Two-step assay means you eliminate all the interfering substances. We do have positive interference and negative interference with the assays. So usually the endocrinologist to an extent understand all these nuances of how these assays are being performed. And it is very important not to treat just the hormone results in front of us, therefore need to take into account the entire picture of what the patient presents to us with. It's very, very important, especially for the endocrinologist, to understand about the different methodology, especially for example, me working in a corporate setting, it's important for me to know which particular assay my lab is using, so that I will understand the limitations of that particular assay. And it's very common that I pick up the phone to the head of the department of biochemistry to say, this particular result that does not match against the clinical picture. Can you please redo this in a different assay? So then she will say, okay, we'll put it in a Roche two-step, and then the results are slightly different. Not common, compared to yesteryears, let's say 20 years ago when the assay was at its nascent stage. Now the assays are much more refined, much more accurate compared to what it used to be. But it's very important at the end of the day for the endocrinologist to understand that each of these tests will have its own limitations, and it's the clinician's duty to put that into context with the clinical symptoms with which the patient presents to us.
You're actually very lucky that you have a cooperative colleague. Many of us are not so blessed, but it's a good message for everyone. When you get a TSH, and don't rush to treat it immediately. Of course, if it's 900 plus, like that patient, the 26-year-old IT guy, then you have to treat. But let's say it's 5, 6, 7, 8, 9, 10. Think twice before treating, and you might want to reach out to your colleagues in biochemistry to find out how it was done. My backup, Dr. Narayanan here is, and 30 years ago when I came back home, I did my fellowship, my DM at AIMS, and I came back and the local civil hospital gave a TSH report of minus 2.5. So I was taken aback. How can it be minus 2.5? I reached out to the local physician who was working there, and he is a respected person. And I said, sir, how do you manage such patients? He said, and don't you talk to the biochemistry people? He said, Sanjay, don't you think I spoke with them? So I said, okay, you spoke with them. What did they answer? The answer was, Dr. Saab, it is an American machine. You think that your MD from Rohtak or Delhi will argue with a machine from America? The American machine is giving minus 2.5, so it is minus 2.5. So that is how it was. Now my backup is I tell them, you may be having a temporary thyroid. You have a TSH of 9.9 or maybe 0.05. You may be having temporary thyroid. Let us, though in my heart I know it is an analytical error or a pre-analytical error. If we work together, I am sure you will be able to overcome thyroid. All you have to do is a little bit of diet and exercise. We will try to avoid the thyroid medication. Maybe we'll give you calcium, vitamin D, but we need to get a good quality thyroid done. So now let us get a TSH ultra sensitive or a TSH third generation. And now we have to write TSH fourth generation because Haryana is also evolving very fast. So usually when you get that done, then the report is normal and then you relax and then you can share the credit with the patient. See, we worked together and we overcame your thyroid. It was temporary thyroid. If we had started you on treatment, then you would have got permanent thyroid. So these are some of the things you have to do in practice.
That tells us that we need diplomacy as well when dealing with such patients.
A little bit of diplomacy and tact. Yeah, so that lab was fine. He did a TSH, but let's send you to another lab where they will do a TSH ultra sensitive. That's a different test. That's like
this
how
is one
Dr.
area
Radha,
where this is one area the patient also gets a bit angry with us when we say, oh, you have done the test, but we need to repeat this in our hospital. Obvious reasons. I mean, the other main hormones which they completely get it wrong are like things like prolactin, metanephrines, where the labs outside completely, and we know for sure that it is not fitting in with the clinical picture. And the patient says, no, I've just done it in a lab. It's good lab, reputed. It's been there for 30 years. Why do you want me to repeat it again in your hospital?
That is a big problem. So then a diplomatic answer to that will be they have done anti-pro-BNP, though you know it's not accurate. Now we will do a pro-BNP, or you just change the number. Yeah, or they have done protein and we will do albumin. These are totally different. So you do something like that.
An interesting story, sir. Just wanted to share. So there are alternate centers where they say we will treat your CKD without dialysis. No? So one of my patients came, he had a creatinine of 8, so advised dialysis, and he said I will take a week time, sir, I will go and come. He came after a month, he showed me a report of creatinine 1. He said sir, I went to the center and the center gave this medicines, so much medicines. After a month, the creatinine is 1, sir. Which lab you have done? So the same center, they have a lab, sir. In this lab, I checked it, from 7 creatinine, they brought it to 1. I just asked them, I'll just repeat one test, which is creatinine. I will pay for the test. And the creatinine was 15. Not 1, it was 15. It is doubled. The simple way to change your creatinine is just swipe it, put 1, that's it. That is what most of the people are doing. So as almost like endocrinologists, we always treat the numbers. Most of the time we treat the numbers. So at least we should be confident over the numbers, from where the numbers are coming from. So the lab has to be a repeated lab, and as Sir said, when we ask the patient to repeat the test, they are somewhat angry on us, but at least the important numbers I ask them to do it again, at least the creatinine, GFR at least, and proteinuria, at least those things I ask them to do it again in my labs, so that I'm confident enough to start some medicine for this.
That's true from a nephro perspective and internal medicine also. the creatinine, the sodium, potassium, these are important. And for colleagues in internal medicine, it's really tough actually. There is a lot of difference treating somebody with acute febrile illness and a TLC of 2000 versus someone with a TLC of 8000. So you need accuracy in TLC as well. These challenges are really there every day in our practice. One challenge, Dr. Ajay, we face is that when Dr. Narayanan and I, let us say we get a TSH of 10, we know that we have to treat. If it's a TSH of maybe below 4, we know that usually we don't have to treat. Pregnancy apart, that would be a different set. But if it's 5, 6, 7, then we have to think whether to treat or not. One of the reasons is that if we over-treat, then our patient may get in trouble. They may get in trouble with Dr. Radha. They might develop an atrial fibrillation, tachycardia. They might have to go to her if we are over-treating, or their bones might get in trouble. So, Dr. Ajay, what is renal osteodystrophy, and what kind of patients did you see when you were a student in nephrology? What kind of patients are you seeing now, renal osteodystrophy? Because I'm sure each and every physician in the country sees a different spectrum based upon where he or she is practicing.
So most of the time we see secondary parathyroid, sir. But I work in a uro-nephrology center, so we have a big urology group here. So we see a lot of stone patients, and we have found a lot of primary parathyroid in our population. But as a nephrologist, what I tend to see is the parathyroid. I tend to keep my parathyroid levels in my dialysis patient or my CKD end-stage patients 6 times the normal. So that is the target which I usually keep. 6 times the normal, which is around, I tend to keep it around 300s to 400s. That is the range which I keep. And I tend to keep my phosphorus within 4.5 with the binders, and calcium. So, but the range of patients with this bone disease is very high, sir, because usually when they are neglected patients or patients who have been taking alternate medicines, they tend to have a lot of brittle bone disease, sir. And very rarely we have seen tertiary hyperparathyroidism, and which we had the parathyroid developing around 2000, 3000. Recently we had a patient who had a PTH of around 2500, and we just wanted to do a sustainability, and we found to have an adenoma also. Even after removing the adenoma, the PTH was high. So probably somewhere there, I'm not sure, sir. But
let's go back to Dr. Narayanan, because now suddenly this discussion is becoming so interesting. And now what I realize, someone listening to all the experts, when we go to a CKM meeting, a cardio kidney metabolic meeting, we know that there will be a particular track of discussion. But now in that same CKM space, now suddenly Dr. Ajay said, this is my PTH target. Renal osteodystrophy is different for different people. So, Dr. Narayanan, first of all, 3 questions for you. Let's take them one by one. First of all, what comes to your mind immediately as Dr. Ajay is speaking? Secondly, why does he want to keep the PTH high? And third, they brought out the adenoma, still PTH is high. So, just a friendly question, what are the differentials?
Taking from the tertiary hyperparathyroidism, as Dr. Ajay said, it's not so common to see a tertiary hyperparathyroidism. But we have got a big transplant unit here in Apollo Main Hospital. So we do see this quite often. And we have had people who are post-transplant, where the creatinine is now completely normal, but the constant stimulation that they have had during the periods of renal failure and dialysis for a long duration has kept the parathyroid hormone and hypertrophy, hyperplasia with a high PTH to such a great extent. Now, post-transplant, they started having a mild hypercalcemia too, with the persistently elevated PTH, where we had to operate on it. And because it's a stimulation, it's not an adenoma as a single primary hyperparathyroidism causing an adenoma, because it's due to a secondary hyperparathyroidism, where there is a kidney failure, which is constantly causing stimulation to the parathyroid gland to cause an elevated PTH. Usually the effect is on all the 4 parathyroid glands. Therefore, often they have parathyroid hyperplasia, and all the 4 parathyroid glands are affected in tertiary hyperparathyroidism due to CKD, long-standing CKD. And my experience is that very, very, very often, if we do decide to go ahead with a surgery for such people, they will need 3 to 3.5 parathyroidectomy. Removing one dominant nodule or one dominant adenoma is inadequate in controlling the disease. And the spectrum of disease, as you rightly said, sir, from primary hyperpara undiagnosed, let's say, for example, where they present with brown tumors and things, to the tertiary hyperparathyroidism, where they might have already had a long-standing renal osteodystrophy, especially given some of the CKD patients, the mobility is also limited. Then the renal osteodystrophy due to the dysmobility, otherwise called the adynamic bone disease. So there is a spectrum of disease that we see with the PTH-related bone dystrophy in context of CKD.
So in the CKM, cardio-kidney metabolism spectrum, K doesn't stand only for EGFR and albuminuria. There are other things to it. Bone health, for example, that's one thing. Another thing will be hemoglobin. We'll come back to Dr. Ajay in a moment. But let's go to Dr. Radha. Dr. Radha, if we overtreat with thyroxine, we run the risk of tachycardia. If tachycardia is persistent, you might get an arrhythmia as well, and atrial fibrillation is well known. So again, if I go back to my student days, we were trained in MD, we were trained in rheumatic heart disease. So that was all we used to do during our 3 years, trying to differentiate between mitral stenosis and aortic regurgitation. Of course, that is easy to do, but that is basically all we did. And in the exam, that is what we were asked. During my MD exam, I had a spotter, and that was a person with a CABG scar, which I had never seen before. It was so rare in my state. There was no cardiologist and there was no cardiothoracic surgeon in the entire state of Haryana at that time. So you imagine in today's MD medicine exam, you put up a spotter for CABG. Though of course, maybe after 20 years, CABG will become so rare that again they will start giving spotters. But right now, I mean, the students would laugh. But that was what my exam was. After that, when I came into endocrinology, and you have to excuse me, I began to think that when I was a physician, so the heart used to consist of the pericardium, because we used to see a lot of pericardial effusion and we used to do taps. It used to consist of the myocardium, the valves, and there used to be a few coronary arteries in between. But now the cardiologist now, this is speaking to 10 years ago, for the cardiologists of today, the entire heart consists only of the coronary arteries. There is nothing else. The cardiologist is not bothered about anything else in the heart except the coronaries. Now again, things are turning full circle. So our cardiologists are aware of the myocardium. Heart failure is a big thing. Atrial fibrillation, electrophysiology has grown. So ma'am, would you like to speak about arrhythmias? What mistakes do we make in the OPD? Why is it that I don't pick up as many arrhythmias as Braunwald tells me there are in the world? What are the mistakes I'm making in my OPD? And if we give too much of thyroxine, how can we worsen these things? So, I mean, it would be nice to learn from your perspective.
See, arrhythmias are quite common, but then it is not something we routinely pick up in the OP as it is prevalent. So most times it's PSVT or paroxysmal, supraventricular tachycardia and all. Most of the times people usually, by the time they go to the emergency, usually reverts by itself, and then the ECG shows sinus tachycardia or just sinus rhythm, and then that's something which is missed out. And most of the times, usually, even if we usually tend to say PSVT, one episode in entire lifetime is fairly acceptable and common. So if it's only the recurrences which needs to be, or we have to be preventive and start them on beta blockers or something. And coming to atrial fibrillation, of course, post CABG and then post any viral pneumonia, sepsis, all these MODS patients are critical care patients. Most of them, atrial fibrillation is the most common arrhythmia we come across. So even if it is, underlying condition is treated, it usually reverts and stuff. But then maybe, like you said, not everyone tends to probably follow up them as 3 years later. We generally tend to repeat a halter to see if there's any, episodes, or they're completely back into sinus, or there are paroxysmal episodes. So that's way of monitoring these people who may otherwise go missed during their OP visits. They are not followed up, especially those who had these episodes during hospitalization. That is one thing. And this sinus tachycardia, probably, most of the young women or people who have mild thyroid issues or subclinical thyroid coming with sinus tachycardia, considered to be, maybe, doing a regular test also probably is missed in some clinical settings where they just call it inappropriate sinus tachycardia, or reassurance is just given to the patient saying it's nothing, your heart just normal range. So maybe it's one way, probably, they're just getting missed.
And Dr. Radha, thank you for this. You've put in perspective some challenges that our healthcare system faces. On one hand, overdiagnosis, and on the other hand, underdiagnosis. Let's ask Dr. Narayanan. Dr. Narayanan, from a thyroid window, two things. Somebody presenting with subacute thyroiditis, which is becoming more and more common. And I'm not sure about the rest of the country, but in the north, after COVID, we had this spurt of subacute thyroiditis and recurrence of Graves' disease. We had not seen so much before COVID. After COVID, it became very common. So that would be one thing. Endogenous hyperthyroxanemia, subacute thyroiditis. How does it prevent? We are physicians listening from across the country to you. So what pointers would you give us? And once you're doing that, along with that, supposing we are over-treating someone with thyroxine, the TSH will tell us later that we have over-treated. But how can we look at the patient's skin, the patient's body habitus, and maybe the pulse, blood pressure, to see if we are, what kind of history can we take or examination can we do, which will tell us that, we are over-treating, and let's take a step back.
Yes, sir. So the first part of the question, post-COVID subacute thyroiditis, definitely we are also seeing more. Like the DKA, for example, we have never seen so many DKAs prior to COVID. We started seeing so many DKAs. That is now seems to be the peak has come down a little bit. But similar to that, the subacute thyroiditis, maybe because of the variants of the COVID, which has happened post the peak of COVID. People started having various manifestations of the COVID. Many of these can be the triggers for subacute thyroiditis as well. And the symptoms per se differs from person to person. Some might have subtle symptoms or sometimes asymptomatic, incidentally picked up on a routine screening, to somebody who is presenting with the weight loss, like to an extent with the frank thyrotoxic symptom, pain in the neck, etc., etc. So this is, and as you rightly said, some may have recurrent episodes, repeated episodes of thyroiditis, although there is generally a window of gap between two episodes that we see. The second part of the questions, what happened with thyrotoxicosis or over-treating somebody with thyroid hormone replacement, what the symptoms could be. Even before the TSH tells us, one thing which we need to remember, although the patient in front of us thinks about a thyroid function test in front of us being normal, because they have got what is called a reference range. That could be from 0.8 to, let's say, 2.7. Technically, the patient might think my thyroid function test is completely normal, still I'm having so much of symptoms. But one thing to remember is, let's say somebody's T4 is normal, should be 1.0, a particular individual. If their T4 moves from 1.0 to 1.8, they may have all symptoms of thyrotoxicosis, but technically the T4 is still within the normal range, the reference range. So these are states where biochemically they are normal, but clinically they are thyrotoxic. The tachycardia, the subtle symptoms, which when often the patient volunteers this when they are specifically asked about these specific symptoms. Have they been losing weight? Have they been sweating excessively? Have they been having disturbed sleep, a shortened duration of sleep, being more emotional, crying without any reason, or being emotional without any reason, being angry without any reason? All these are symptoms and signs which could suggest that the patient has been over-replaced. One other thing would be the weight loss, the subtle weight loss, the 2 to 3 kg weight loss, especially when they have 3-4 symptoms together. Then that tells us that the patient is being over-treated. As rightly said, Sir rightly said, that the two important aspects which we always have in mind when we are even subtly over-treating, because these are hormone replacements over a time period. So even though the dose is only a little bit over, the cumulative effect over a time period is quite significant over the heart in terms of cardiac arrhythmias and over the bones in terms of osteopenia or osteoporosis, especially if this is in a postmenopausal women or an elderly gentleman that we are over-treating. We need to be really cautious.
That's true. And here in our OPD, what we do, we ask the patient and the person who is attending. So if there's a son or a daughter-in-law accompanying the person, then we'll say, are you getting more scolding than before? If the husband is there, then we'll say, is there more marital disharmony, discord than before? And one of my favorite questions is, do you get a cup of tea in the morning? So the answer may be, yes, I do, or maybe I make the tea at home. The husband may say that I make the coffee at home. And then the next question is, do you get it with a smile? And then suddenly the husband says, yes, the smile is missing now. The tea is still there, but the smile is not there. That means the patient is not well. Now, this is a feeling kind of a question. It's not a number question, but it tells you that something is wrong. That something may be that the hemoglobin has dropped. It may be that the TSH is low. It might be that the creatinine has risen. but you know that yes, now we need to work further, and then you advise a TSH or a PTH or whatever test. Now the patient will agree, because now you are trying to treat that missing smile. So with excessive thyroxine replacement, the patient may become dark. In a light-skinned person, this is one of the first things that you will see. The person is becoming darker. And like we said, Dr. Narayanan always volunteers to answer the difficult questions. So he will answer why this happens, what happens in the pituitary. So first of all, the patient will become dark, and the skin will lose its luster. The nails will become brittle if you are over-treating with TSH. And this will be true in nephrology as well, in a CKD patient. The pulse may go up if you are able to check the resting pulse, or the patient gives you. But before that, the family will say that, yes, this person is getting irritated. And then we'll ask the patient, do you feel that you are driving your life in 5th gear, 4th gear, but everybody else is in 2nd or 3rd gear, irrespective of who is with you in the family or at the workplace? And the answer is yes, I feel that I am correct and everybody else is wrong at work and at home. I am a daughter-in-law, so I am forced to listen to other people. But from inside me, I don't want to listen to my mother-in-law anymore. So these are common symptoms or signs which will tell you that, yeah, we are over-treating. And then this helps you. Actually, what Dr. Narayanan said now, he made things more difficult for us, because he said the TSH should be 1.0 for a particular person. It can be 2.0 for a particular person. But these kind of things will tell you what TSH to aim for. Another number is, Dr. Ajay, that is hemoglobin. So from a kidney perspective, and let's talk about hemoglobin now. First Dr. Ajay, Dr. Radha, and then Dr. Narayanan. So there is something known as the Goldilocks zone. Goldilocks was this young little girl who went to the forest, and she entered the house of the bears. So one bear was too big, another one was too small, and one was right in between. So hemoglobin is like a Goldilocks metabolite. Why is it so in kidney disease? Why is it that you don't want too much of a hemoglobin? I mean, I would be very happy if I had a hemoglobin of 17. I would show off to all the ladies and girls around me.
So two things there. So that was a study. So in dialysis patient and in CKD patients, if the hemoglobin was more than 12 or 13, the rate of stroke and cardiac events was higher, sir. The thrombotic events were more higher. So we always tend to keep in our dialysis population and in our CKD population, hemoglobin was around 11 to 12. So that is our target. Keeping the hemoglobin around 11ish or 12ish. So that is our usual target. So a higher hemoglobin of 13 and 14 usually has a higher risk for thrombotic risk. Stroke, usually stroke, cardiac, severe risk is much more higher, sir. So that is a major reason why we don't have it in a very higher range. We tend to make sure the erythropoietin or darbepoietin doses such a way like the hemoglobin is around 11ish or 12ish. Once my dialysis patient hemoglobin touches 12, I ask them to skip the dose of erythropoietin for 2 weeks so that it comes around 10, and then I again replace it. So I don't let the hemoglobin go more than 12, or I don't let it go less than 10. So that is the range which I usually put, 10 to 12. So that is the way we play it, sir.
So there is this comment, Dr. Ajay, this is shared by a nephrologist. He is from Jaipur, Assistant Professor Saurabh Sharma. And what he says, thank you, Dr. Ajay, for pointing out all these things, because we are always teased in Rajasthan for being retroperitoneal doctors. So there is this Hindi song, Choli ke piche kya hai? And Dr. Sharma says that we are teased for being peritoneum ke piche kya hai wala doctors. So thank you for pointing out to all of us that there are so many things that the nephrologist has to do. It's not just about looking at the EGFR and albuminuria. It's not about the CKM that you would learn in maybe a pharma-sponsored talk. All these things are also going on behind the scenes. Dr. Radha, madam, what about hemoglobin from a cardiac perspective? There also, is it a Goldilocks kind of a hormone, or is more the better?
No. Like Dr. Ajay has mentioned, I think higher the hemoglobin, of course, we have primary polycythemia and secondary polycythemia also. So if your hemoglobin and PCV are tend to be on the higher range, we have to look for any hypercoagulable disorders. Their future risk of having events, probably a stroke or thrombotic episodes, is usually on the higher side. So that's how especially we know that if young population, this is one of the situations we usually even evaluate for if they have any hypercoagulable state, and hemoglobin and PCV are one of the indicators for that. Similarly, low hemoglobin values, of course, anemia in heart failure is one of the most important components. A lot of trials of late, should we treat it or when should we treat it, the cutoff value and stuff. So rather than just going by the hemoglobin value, so 11 is acceptable. Anything less than 11, we look at the ferritin and the transferrin concentrations. So if at all the ferritin is on the lower side or the percentage transferrin saturation is on the lower side, even though the hemoglobin is 11, we ideally treat it with IV injections or something, so that basically they're all just predictors of recurrent hospitalization rate or people going into failure and even mortality indicators. So that is very crucial. So if you are having someone coming with repeat hospitalizations, or if there is an anemia component, that is something which needs to be identified and has to be treated. Similarly, if there's underlying anemia, it's a hypercirculatory state, not just it can cause tachycardia. Even for patients with underlying coronary artery disease or LV dysfunction, anemia itself can be a a trigger or a precipitator for ischemia. So these patients, the anemia itself can cause chest discomfort, even resting angina if there is a significant anemia in patients underlying CAD. So it's a very important thing that it needs to be identified and has to be treated.
Thank you for raising these points, and especially if somebody has sudden onset anemia, whatever the etiology may be. There might be one lady who is happy with a hemoglobin of 4 because she has lived with a hemoglobin of 4 throughout her life. She is not breathless. She doesn't complain because she has never tried to climb one flight of stairs. So her life is such that she has never moved. So she doesn't have breathlessness on exertion. Exertion, the definition is different for everybody. And on the other hand, there might be someone who developed anemia suddenly for whatever reason, and actually angina might be precipitated. Our topic for today was thyroid and the missing link. But what we see is there are so many links now between all these subjects. I am reminded of a very famous person, Thiruvalluvar, who wrote the Thirukural. Dr. Narayanan, could you speak? This is an all India audience. Thiruvalluvar presented a quadruple where he said that if you want optimal therapeutic outcomes, you have to make sure that all 4 angles of the quadruple are equally strong. He said it should be the patient, the physician, the pharmaceutical product, that is the drug, and also the people who are taking care, the caregivers. So 4 Ps, the patient or the person with disease, the physician, the pharmaceutical product, and also the caregiver or attendant, that is people around us or the public, everybody is required. Dr. Narayanan, in today's endocrine practice, how important is our Thiruvalluvar's words? Do they help us? I mean, whatever comes to your mind and any problems that you had faced in the OPD last week, getting all these 4 Ps together.
Well, it's valid for time immemorial, I would say, because there is no topic that he's not touched. Such a great person who has advised us, and his advices still remain valid for our current day practices. There is one more Thiruvalluvar's, another verses which tells that how to treat a person, how to treat a disease, where he says there's no point in treating the superficial symptoms, but you need to identify the root cause. The Kural states like Noi Nadi, Noi Mudal Nadi, Adu Tanikum Vai Nadi Vaipachayal. That means you can't treat just the superficial symptoms of the patient, not just the patient alone, but you identify the root cause, then treat, then the disease can be eliminated. So he's given several such advices for a physician who's treating the disease right from those days.
You're right. And for example, that might be just taking a history and finding out why anemia has occurred. What's the point of giving erythropoietin and iron, IV iron, if you don't know why anemia took place? So thank you, Dr. Anand. Dr. Ajay also had something to say.
Yeah, I just wanted to just put I have a small doubt, sir. So right now there's something concept called pink salt going on, sir. And non-iodized salt and iodine is not that good for health. So I just want to take your point, sir. As a nephrologist, I'm against pink salt because it is high of potassium, which is not good for our patients. So I just want to take from your as a endocrinologist your point, sir. Is non-iodized salt is good? So whether that is good or iodized salt, iodine fortification was just made so that hypothyroidism, the rate of hypothyroidism could be going on. So what is the take on this non-iodized salt versus iodized salt? What is the take on?
We should have iodized salt. Certainly, there is no reason to argue with that. If someone is using pink salt for religious purposes or cultural purposes, we say you go ahead and do that unless your potassium is high. But don't forget iodine because that is important for your brain. And supposing someone says, let us say someone is from coastal Tamil Nadu, and they say, I eat fish 3 times a day, I have enough iodine. This iodized salt is meant for people from Himachal Pradesh because that is where the Kangra Valley study was done. The answer to that is 50 years ago, the iodine in the fish was different. Now there is so much of pollution. Pollution has not spared either the Arabian Sea or the Bay of Bengal. And now the fish are also drinking polluted water. So the iodine has gone down in them. You must take adequate iodine. And the other message that you would want to give is that even in the gynae or obstetric guidelines, when they talk about micronutrient supplementation in pregnancy, they specify that it should be an iodine-containing micronutrient supplementation. So you say that when the obstetric people are specifying, even for an unborn baby, it's even more important for you. The only exception I can think of, Dr. Narayanan, is somebody maybe with very severe Graves' thyrotoxic crisis, which I have not seen for so many years now, and where you are struggling with methimmercazole 60 milligram and lithium. I mean, then you might want to say stop iodine, but not otherwise. I cannot think of any other.
Yeah, true. We have had people who presented with cardiomyopathy and heart failure as the first manifestation of Graves' disease. I particularly remember an African lady who had bone dystrophy. She was very young, 30 odd year old lady who presented with heart failure to one of our cardiologists at Apollo. And then I was involved retrospectively because of the thyrotoxicosis. It was a thyrotoxic cardiomyopathy. We treated the thyrotoxicosis. She presented with a EF of around 25 or 30. And then gradually, it took, I think, almost 2.5 years for the EF to gradually improve to an acceptable, workable level where she could do her daily activities. So in those sort of situations, are people who have got severe thyrotoxicosis with a huge goiter, then yes, in those sort of situations, we advise them to avoid like seafoods, for example, which can give a big iodine load.
And these patients we used to have like an epidemic earlier. So this is one thing which mercifully we are not seeing now in endocrine or cardiac clinics, thyrocardiac disease, which used to be really, really common 20 years ago. And now we don't see it anymore. It has just become extinct because patients are getting treated earlier. These are important things. Potassium is really important. But what we see, Dr. Radha, is that Thiruvalluvar, he taught us that we should have the patient, the physician, the drug and the person taking care all together. But now we see even from a CKM point of view, what Thiruvalluvar is teaching us even now, after so many thousands of years, is when you see the patient in front of you, don't think only cardiac, don't think only kidney, don't think only metabolic, you think like a physician. So the fourth person is the physician, and that is perhaps the most important. But the physician, how many heads can you have? I mean, how many brains can you have? You have to think of anemia, parathyroid, glucose, blood pressure, the patient's quality of life, the attendants who are fighting you, then the cost capping, you cannot spend beyond so much money in that particular patient. So Dr. Radha, how do you manage as a cardiologist? How do you manage all these things together?
Like I said, I think one of the main reasons why I actually chose cardiology is because I think you still stick to your basics and you actually tend to think like a physician. You can never leave your diabetes spectrum, never the hypertension, never the renal aspects, and the cardiology is an added thing. In fact, you have to concentrate on all these things when you actually see someone in your cardiac OP. So your mind has to work in all the directions. But like you said, it's tough to handle everything. So sometimes, like let's say, isolated pericardial effusions, who we can see just the hypothyroidism or untreated hypothyroidism can also cause, actually massive pericardial effusions. Recently, I also had, one patient such. So sometimes I feel it's just beyond just our hands to evaluate such cases. That's when we have to stop overthinking or try to feel that, I can evaluate or diagnose that and actually send it to your concerned endocrinologist and rheumatologist to, evaluate the further process. I think that's quite important actually. Than though we tend to try and find causes and stuff, sometimes things are just beyond our.
That's important because in this patient you have described, I'm sure if you send to Dr. Narayanan, then he will start thyroxine 12.5 if the person has got pericardial effusion. He is not going to start with 100 microgram. So that means we need to speak with each other. If you tell him that my patient has got pericardial effusion, ejection fraction of only 25%, his dosage and his monitoring will be totally different. The thyroxine will be the same, but the strategy will be different. On the other hand, if you say that the myocardial function is perfect, then his dose will be different. If you say that the patient has got angina and I'm struggling with just basic, symptom relief for angina, again he will go very slow. On the other hand, if your patient doesn't have angina and also doesn't have anginal equivalents, and you've taken a good history, then his speed will be different. Same way, Dr. Ajay, the question is, how are you able to manage so many things in nephrology? Do you have a checklist in your mind? I mean, any ideas
So
for us?
most of the time, sir, so we always think of, as a physician, sir, what I feel is nephrology is just an extension for me, and it is have not brought me to a different plane. I have always been a physician, and I'm just working as a physician, and just the nephrology is just like an add-on knowledge to my cap, sir. That's it. So I just tend to see the patient in the whole way. So just from the basics. So as I've been trained, it is like be strong in your basics. So from thyroid to everything will, as you said, sir, as there's always importance in taking cross consultation, but as in our patients, what we tend to see is as a whole, from diabetes, hypertension, every point of view, we tend to see it as a whole, sir. And whenever, as you rightly said, there's always a niche way wherever there is required, the cross consultation has to be got, and at the right time it has to be obtained. And in a whole manner, we tend to see the patients as a physician, and never thought whenever I manage a patient, never thought away from as a physician. Always think as a physician, and nephrology is just an add-on point. I know few points in nephrology, that's it, but always a physician. So think as a physician when you see the patient. That as it holds good for me, sir.
This is, I think, the best thing of today's 4D webinar. Our super specialist, Dr. Radha, Dr. Ajay, both saying the same thing. So whether you are thinking heart or you are thinking kidney in your OPD, you are thinking the human being first, and you have to think of each and every aspect, not only biomedical, but also psychosocial. We have not been able to cover that today. And thyroid also. If the person comes to you with altered heart rate, altered blood pressure, altered myocardial function, pericardial function, do think of thyroid. If the report is consistent with what you're thinking, fine. If it is inconsistent, please reach out to the endocrinologist. And for Dr. Ajay also, if you're struggling with the bone parameters or maybe with cardiac parameters, then again, think of thyroid and think of the endocrinologist. Dr. Narayanan, you've trained in the West and in India. Now you are working in Chennai. You see urbanites and you see people from rural India as well. And I'm sure you see a lot of people from abroad, people who come for medical tourism. Do you need a different brain? Is the Western physician's brain different from the Indian physician's brain, or is it a Jekyll and Hyde kind of story in your brain in the OPD?
Sir, I think
that was a teasing and affectionate question for anybody who takes it otherwise.
The spectrum of disease probably was very different. The number of autoimmune diseases that we used to see in the West, for example, when I moved back to India in 2013, I would have seen a lot more type 1 diabetes. I used to see a lot more type 1 diabetes in the West compared to India, but now we have started seeing more of it in the urban setting in India as well. The requirement from the patient perspective could also be slightly different. The demand, the litigations, many aspects are different between the West and the East. The type of spectrum of disease within endocrinology, if we talk, because of the population that we have, I would have said what I would have seen there in 7-8 years time duration, I could see here in 6 months time duration. I've managed more number of pheochromocytomas, and we have done so many pheochromocytoma surgery in the past 10 years compared to what I would have done in the UK over the next 20 or 30 years time duration. So the volume is high, and each of these diseases like pheochromocytoma, Cushing's, they present, each individual presents in a very, very different way. So the demand on us in how to manage these patients is also very, very high, that we update ourselves, try new techniques. What works in one particular patient with pheo or Cushing's may not work in the next patient. So the mind is always open to all these different aspects, and I think that is stimulating us to be alive, and as you rightly said, to keep the brain cells active without losing the memory.
Thank you so much, and very well said. It's been 1 hour and we didn't even realize how the time flew by. That is what happens when you speak with experts, and especially experts who are human beings. This is what I like best about today's 4D. We have so many well-read people in the country, isn't it? I mean, all of us, we call ourselves well-read. But then being well-read and yet being humble, being grounded, thinking of the patient as a human being, accepting our shortcomings and our limitations while utilizing our strengths to help people. This is what we get from all our 3 team workers today. Dr. Radha, thank you so much for being with us. Dr. Ajay, thank you so much for that wonderful smile. And Dr. Narayanan, thank you for putting things in perspective. Our topic in 4D is usually diabetes. Today we branched out into CKM, cardio kidney metabolic syndrome. And in that we wanted to talk about a less explored topic, thyroid. But we ended up talking about the entire spectrum of health and healthcare in the country. I hope everyone has found it enriching. There is a comment for all 3 of you. This comes from Christian Medical College, Bangalore. And Nitin Kapoor says, I really enjoyed, his words are, I really enjoyed listening to 4D. Now, if I have a problem, I know whom to show in Chennai for my heart and my kidney and my endocrine system. So that is a compliment for all of you. Thank you, everybody. To everyone who is watching, stay tuned. Every Friday, we are there with you for 4D. Keep going strong and keep taking care of your patients. Good luck and
Thank you.
Thank you so much, sir. I think you moderated the session so well that we were all put at ease. It was more like a friendly discussion. It wasn't like first time we are meeting on stage together with 3 different people from different spectrums of the cardiology, nephrology, etc. You've done it so wonderfully. Thank you so much for taking along with us.